For now, we're going to Dr. Abdallah السهيل, who's a consultant in palliative medicine, geriatric medicine, currently practicing in King Fahd Medical City. Dr. Abdallah is one of the great experts in Saudi regarding the palliative issues in geriatric medicine. And today he's going to speak to us about the role of palliative care in the management of patients with advanced dementia. Without further ado, please join me in welcoming Dr. Abdallah for the great lecture, inshallah.
Thank you, Dr. Walid, for this introduction, and thank you for Scientific Committee for inviting me for lecture today. Today, going to talk about the role of palliative care in Alzheimer, and I would like to thank Dr. Abdullah because he make my life easy for today's presentation. Today, going to focus on the principle of palliative care, then the role of palliative care in end-of-life and symptom management. WHO defined palliative care as an approach that improves quality of life for patient and family facing life-threatening illnesses, and the role of palliative care to prevent and relieve suffering by mean early identification and capable of assessment, treatment of pain and other problems, physical, psychosocial, and spiritual. So the key word here is that the palliative care, taking care after patient with incurable and treatable disease, and not looking only for the patient, but looking for patient and family for all aspects of suffering, physical, psychological, social, and spiritual. And here is the kind of suffering that multidisciplinary palliative care team should identify and treat: physical, social, emotional, and spiritual. And this is from WHO report. The common disease that's seen by palliative care, the majority of patients cardiovascular, then cancer, then after that COPD, HIV, diabetes. The Alzheimer is 1.65% of patients in palliative care service. And this is what we call the death trajectories. We know in palliative, we're looking after patients who have incurable expected death. So if we rule out sudden death, that take 40 to 30% of population, 60 to 70% of population will have one of those three trajectories. Here, okay, we'll go back. Okay. The first one in the top is the cancer. X is the functional status, and Y is the time. So in the cancer patient, he gonna have normal functional status until he diagnosed with cancer. So then he had drop of his functional status over a month or several years, and death. In the middle death trajectories, the patient have organ failure, like COPD, heart failure, etc. The patient will have normal functional status, then you have acute problem, so the functional status drop, then improve after the acute problem resolve, but he's not going to his baseline. Then he continue in that stage until he get another acute problem, and the same, he will not go to his baseline until he will get acute illnesses that can kill him. The third one is the one that's important for us in these lectures, is the dementia and frail. The patient will have slow decrease in functional status over years until the patient death. And here is our focus in our lectures. And here's the stage of Alzheimer's disease. We have mild, moderate, and severe. Mild, when there are only memory loss and not a lot of functional decline. Moderate start to have more functional decline and more memory loss. And severe one, the patient will have bedbound, unable to do activity of daily life, and he need care for all his problem. If we ask our colleague, when the palliative care role started? In the mild, moderate, or severe? Anyone can answer? Okay. I can. Okay, Dr. Walidi answering. Actually, we only get patient transfer or consult in severe stages, and this is not our recommendation. The referral or consultation to palliative care has started from the beginning, from the diagnosis. We know that our role is limited in the beginning, but our role increases over time, and the role of geriatrician or neurologist will decrease over time with advances and decreased functional status until we reach the severe case when he needs end-of-life care. And at that time, we recommended transfer patient from primary team, either neurologist or geriatrician, to palliative care. So our role is limited in the beginning, but we have to involve in the beginning, and that will help geriatrician neurologist to take care after the patient. So what is our role? Here, this slide summarizes the patient journey from the beginning until death, and because we support the family after death. So we can divide it to 5 phases. Phase 1, if the patient have prognosis more than 6 months. Phase 2, when the patient, we expected he gonna die within 6 months. Phase 3, when the patient have 2 weeks to live. And 4, a day of death. And 5th, to support family after death. Another question is, what the majority of the patient, Alzheimer patient, refer to palliative care internationally? It's gonna be refer in phase 1 or 2 or 3. The majority of patients actually transfer to hospice in phase 3 or consult palliative in phase 3 at dying process. And at that time, we didn't have a lot of to over. All the study that shows palliative care effective to control symptom, improve advanced directive, improve goal of care, decrease aggressive interventions if the patient referred to palliative early stage. With late referral, the quality of patient symptom is not controlled. So let's go to one of the important questions: how we know if the patient gonna live for less than 6 months or more than 6 months? Actually, the data shows that healthcare providers have very poor prognostic estimation. Very poor prognostic estimation. In this shocked study, they ask staff in nursing home taking care after Alzheimer's disease, are you surprised if the patient died within 6 months? 99% of them, they said yes. We will surprise if the patient died within 6 months. In reality, 71 of those patients died within 6 months. This reflects on the family. Majority of the family unaware that Alzheimer is terminal illness, and the patient have all the symptoms of sign, said that the patient in advanced dementia, and the family is still not aware about that. And this reflected on the aggressive intervention the patient will get. Though if the family unaware about the prognosis and the staff not aware about the prognosis, so majority of those patients will end up in the ICU, intubated, with big tube, even with dialysis. So this is the bad death and opposite of good death that Dr. Khnezan mentioned. Majority of our patients in Alzheimer, we know as a clinician to die in short period. They die in ICU without allowing family to visit them. And some of them actually, they get aggressive treatment and they like CPR or even dialysis. This is the reality. So how we know or expected the death of Alzheimer? Unfortunately, the MoCA and mental stat tool help to diagnose the cognitive impairment, but not help to recognize the functional problem. And that's why it is not good tool to predict the survival. The tools that include the functional is CDR, FAST, and GDS, and those can estimate prognosis more than Minimental or MOCA. And this is the tool that we use widely in palliative care, FAST. Any patient with 7, that's mean he gonna die within 6 months. There is a lot to study about the estimation of prognosis in Alzheimer's disease. Study shows that patient with recurrent pneumonia, he gonna die, 47% of them, they're gonna die within 6 months. Patient with recurrent fever or problem with eating also had poor prognosis. Patient with hip fracture also had poor prognosis. And I think this is this is the most important slide I have today. If we get this slide, I think we succeed to deliver the message. When you're gonna transfer patient to palliative care? Transfer patient according to National Hospice and Palliative Care Organization, they said if the patient have FAST 7, that means he become dependent in all activities of daily living and have incontinence of bowel and bladder and have speech limited to 1 to no more than 6 usable words, plus one of those, either medical or nutritional complication, aspiration pneumonia, upper tract infection, recurrent sepsis, stage 2, 3, or 4 pressure ulcer, or greater than 10% weight loss, or serum albumin less than 2.5. If he had FAST 7 plus one of those, that means he's gonna die within 6 months and he become eligible for palliative care transfer and hospice care. So what our rule in patients who have more than 6 months to live? The major rule is advanced directive and proxy, as Dr. Abdallah mentioned. We know that the patient in early stage can make a decision. So that's the time to ask him. Ask him about the proxy, surrogate decision maker, advanced, and ask him about the advanced directive, the goal of care, how aggressive we're gonna be. Advanced directive mentioned by Dr. Abdallah Khanizan, the most important rule for palliative in early stage. What about less than 6 months? Actually, the most important to discuss the DNR and discuss the place of care, either hospice or home. The most common symptom at this stage is agitation, dyspnea, pain, and ulcers. Agitations is the most common because the patient is unable to express himself. So if he hunger, thirst, pain, fever, etc., he gonna represent it as agitation. Antipsychotic is not recommended except if the patient have harm himself or harm others. Otherwise, we have to treat the treatable and correct the correctable. Paracetamol as empirical treatment for agitation, there is many trials on that and shows very effective to control agitation because there is hidden pain. Not recommended to use mementin or cholinesterase inhibitor to control agitation in the stage. The pain is very, very common, under-treated and under-diagnosis. We think that Alzheimer have poor perception. Actually, the data shows that cognition decrease, but still the patient have good pain perceptions. So the pain will reserve until the end. We didn't have a numerical rating scale for those patients, so alternative is going to be facial expression or Band-Aid. The most common treatment, paracetamol first line, non-steroidal is not recommended, opioid severe pain. Paracetamol is the first line to treat the pain for patient of Alzheimer at end stage. Non-steroidal is not recommended because a lot of side effects. Opioids is recommended for severe pain and as a second line after paracetamol. The data actually shows that opioid can decrease delirium on those stages rather than increase delirium. In phase 3, less than 2 weeks, we have to discuss with the family. We have to, what the sign of imminent death? Death rattle, chance to breathe in, motor activities. So at this stage, we know that the patient gonna die within hours or days. And unfortunately, we get referral at this stage. when we nothing to do, and most of the patient at this stage DNR, and not good time to discuss the DNR. So at this stage, we have to inform the family, send the patient to single room, make visiting hour open, allow to watch her, and discontinue all medication except for symptom control, like opioid, haloperidol, glycopyrrolate, and discontinue vital signs. Unfortunately, we've seen sometimes the patient put in the monitors. So family, rather than taking care after the patient, just looking for the number, the blood pressure low, heart rate high, etc. So no monitoring, no vital signs, no medication, even diabetic hypertensive medication we have to stop. And unfortunately, majority of Alzheimer's disease actually die in ICU without allowing family to visit them. And this is against the approach for good death. Antibiotic is controversial. Majority of the patient die on antibiotic. However, one of the signs of imminent death is fever because the patient unable to swallow, so he had aspirate. So we not recommended if we confirm that the patient have imminent death to give antibiotic for this stage. Okay. Phase 4, when the patient die, here start to take care after the family. The maximum support of family at the day of death, and this extended for up to 1 year after death. Our approach in our hospital, the psychologists contact the patient after a few weeks after death to recognize the patient with normal grief and abnormal grief. For normal grief, he called them 1 or 2 times. For abnormal grief, maybe and ask them to come to the clinic and get medications. I end up with this slide, with this study, the very interesting study in Cochrane Review, Palliative Care Intervention Advanced Dementia, published in 2021. They include 10 trials. They compare centers with treated Alzheimer without any palliative care service, and other centers who treat the Alzheimer with palliative care service. And they're looking for different outcome. One of the outcome is comfort in dying, means control the symptom, agitation, pain. And here, 5 study looking after that. As you see here, favor usual care in this side, and for palliative in other side, majority of the study support that the palliative care involvement in the service will make the patient die in comfort. Also for quality of life, one study looking for quality of life and shows that palliative care involvement make the patient quality of life better. Documentation of advanced directive, 2 study looking for advanced directive and found that advanced directive documented well. And the other study looking for goal of care and found that goal of care discuss if the palliative care involve. And last one, even the conflict in the family decrease if the palliative care involve early in the stage. And this is the summarize of our role in cancer, in Alzheimer's disease. Thank you.